Going to intro our speakers for this evening. First, we have Dr. Foushee, who is a lifelong resident of North Carolina, Central North Carolina, with a doctorate in pharmacy from Campbell University and a Master of Applied Science and Population Health Management from Johns Hopkins University. Over her career, she has worked in community pharmacy, rural and urban primary care, academia, and health system pharmacy as well. As the first clinical pharmacy practitioner at Benson Area Medical Center and now manager of the Carolina Assessment of Medications program, the population health pharmacy team at UNC Health, her career is focused on expanding pharmacists and technicians' roles in patient care, advocating for immunization privileges, and supporting comprehensive medication optimization services. She has served NCAP in various roles, including 2 terms as an at-large board member in leadership positions in the Community Care Forum and Ambulatory Care Academy, and currently, as NCAP's president, nationally, she has represented North Carolina with the American Pharmacists Association and taught for their certificate programs across the country. Outside of work, she enjoys family time, snow skiing, hiking, and taking her Jeep out for wind therapy. And then our second speaker for the evening is Penny, who many of you already know, but just to formally introduce Dr. Penny Shelton, she is the Executive Director of the North Carolina Association of Pharmacists. She also currently serves as the President of the National Alliance of State Pharmacy Associations, representing all 50 states, and is widely recognized for her leadership in advancing pharmacy practice, policy, and reimbursement. So without further ado, I'll pass it over to our speakers for this evening.
Good evening, everyone. It's great to be with you. I know Leigh and I are looking forward to bringing this topic to you. Let me just go ahead and jump in. We have quite a bit of information for you to share. I think what's most exciting about this is it's coming on the heels of some really positive changes in legislation. And I am actually, Ty, my slides are not advancing now. Let's try this. We'll use the little things on the left-hand side. All right, so here we go. First of all, as usual with anything that's ACPE accredited, want to let you know that neither Leigh nor I have any financial relationship to disclose with regards to the content for this presentation. With regards to learning objectives for this evening, what's important to share with you is we want to bring some information about more recent changes in statutes and regulations related to collaborative practice. Also want to identify some key components or changes that have occurred from the way that collaborative practice used to have to be conducted in our state versus now the greater flexibility that can be built into collaborative practice. And so really sort of trying to reveal like what are those key changes so that people are aware of those. And then third, we also want to introduce you to some best practice processes. So when you think about how do you go about getting started, or if you're already involved in collaborative practice, how do you go about maybe making the leap to update from the traditional type of collaborative practice agreement to a collaborative practice agreement under the newer regs. So really just very briefly, I'm not going to go into a great amount of detail on this slide. You will have access to these slides as the link is in the chat for you. But just want to emphasize, we have been trying to really modernize collaborative practice for a very long time, going back to 2017 and working with stakeholders all the way up until really last year. We were finally able to get it across the finish line, and it was signed into law by Governor Stein on July 1st of 2025. So why I think this is what's more important is why have we been so persistent about trying to modernize collaborative practice? So some of the things that when we kind of sat down and looked at what it is that we want to do with collaborative practice, we kind of really looked to where are the barriers that are occurring, and also what's happening with collaborative practice in our state with regards to, late 1990s is when collaborative practice was first approved in North Carolina. And so after 20 plus years of collaborative practice authority in our state, less than 5% of practicing pharmacists were really practicing as CPPs under a collaborative practice agreement. Most of those were in our health systems, less than 10% were in the community, and we had absolutely zero practitioners in long-term care. And when you think about geographically, where were our CPPs positioned within the state? Almost all of them were actually west of I-95. When we think about really looking at how collaborative practice sort of evolved across the nation, many states had moved away from collaborative practice agreements that were patient, doctor, drug disease specific. But North Carolina was one of the first to introduce collaborative practice, and our collaborative practice authority was still sort of had that particular limitation or restriction that our agreements had to be patient doctor specific and also disease specific. And it made it extraordinarily difficult to provide collaborative practice in a number of situations like transition of care, population health. And so there were a lot of great needs as healthcare has evolved, needs have grown, more gaps in care were growing. We needed pharmacists to bridge those gaps. There was a lot more need that unfortunately collaborative practice agreements, the way that they had to be conducted in our state, just could not cover. Also, the supervising physician requirement and the wording around that really it prevented CPPs from being able to take referrals directly. Also, the use of other advanced practice providers, so our nurse practitioners and PAs in our state, those had grown in that same 20-year window, had expanded 2 to 3-fold, and yet CPPs could not collaborate with them. So when we look at sort of some statutory limitations, those things that we just mentioned, they predated the all-PharmD education. Also, our state had really not kept up when we think about what was happening in other states and really opening up collaborative practice around population health. That was not the case in our state. And then our collaborative practice authority had become, in the eyes of a lot of national leaders, including NASPA, which is the organization that Ty mentioned that I currently serve on their board and past president of that group. North Carolina had become viewed as one of the most restrictive, not looking at it as we have pharmacists doing amazing things in healthcare in our state. So when I say it was viewed as one of the most restrictive, I'm specifically referring to policy, like looking at our language in our laws and in our regulations. And North Carolina was now viewed at the time of running our legislation through all of those attempts up until 2025, when we finally got it passed, we were viewed as one of the most restrictive in the nation. And so all of these sort of, you can view them as unnecessary barriers or maybe just, antiquated verbiage in our law compared to maybe some need for greater modernization. What was the negative impact? And it was really impeding access to care. It was affecting the quality, the timeliness, the efficiency, and it was also driving the cost. It was actually driving up the cost of care in many cases. So the modernization of our collaborative practice authority as it stands today, with the passing of the law in 2025, it builds in now tremendous flexibility. And because of that tremendous flexibility now, which I'll be talking more about in a minute, it now really opens up the doors for a great deal of expansion of collaborative practice into all practice settings. So first thing, before I talk about those changes, those key changes, what's important to talk about first is collaborative practice under a collaborative practice agreement can only be conducted by a clinical pharmacist practitioner. So we'll refer to those as CPPs. So it's important for you to know that the law that was passed in 2025 did not, so the word "no" there on the screen, did it change who can be a CPP? And the answer to that is no, it did not change that. The definition for a clinical pharmacist practitioner remains the same under the new law as it did before. There were no revisions made to the scope or the meaning of the CPP designation. However, although qualifications as to who can be a CPP did not change, there were other changes that will go into effect that the group that is responsible for approving CPPs and issuing CPP credentials, or the number, the CPP practitioner number that CPPs have through the Board of Pharmacy. The group that reviews that information, there are changes that have happened behind the scenes because of the new law, that although the qualifications as to who can be a CPP did not change, the way that a CPP is being approved has changed. And so I'm going to speak to that. So first off, let's look at that definition. Clinical pharmacist practitioner means a licensed pharmacist who meets the guidelines and criteria for such title established by the joint subcommittee of our medical and pharmacy boards. And these individuals are authorized to perform medical acts, tasks, and functions. What is different now is that patient, doctor, disease, drug specific language has gone away. And now we have more general, very flexible language that is viewed as for drug therapy, disease, and population health management. So that's important. Keep that in mind as I roll to the next screen. So when we think about requirements for CPPs, yes, there are some general requirements. You have to fill out an application to apply. There is a fee for that. There's information on the screen and the website where you go to be able to find step-by-step instructions to become a CPP. You apply through the licensure gateway through the Board of Pharmacy. What is important is you do have to have a signed collaborative practice agreement in place before you apply. So in other words, if you've never done this before, and Leigh's going to be talking more about that in a little bit, but you have to have a collaborative practice agreement. So you have to have a physician willing to collaborate with you and an agreement of what it is that you're going to do together. And then you apply to be considered a CPP. But here's what's different. The Board of Pharmacy is no longer reviewing collaborative practice agreements. You're no longer required to upload those collaborative practice agreements. So your application and the issuance of your CPP is not contingent upon what is in that collaborative practice agreement. There's also some general information around, like, you have to have more continuing education than if you're than non-CPPs. So a CPP has to have 35 hours of continuing education each year. And then, of course, there's notes and things that you have to adhere to with regards to your supervision. So when you're being supervised by your supervising physician, there's some guidelines that you have to follow with regards to documenting your meetings with your supervisor and so forth. And in maintaining that information, it's your responsibility as a CPP to maintain that information, a copy of your collaborative practice agreement, a copy of your supervision notes. All the information that's related to your collaborative practice agreement must be maintained on site where you practice as a CPP. So I presented that slide first because this is the part about when you apply, because you're no longer required to upload the collaborative practice agreement. We've had some calls, people have asked, but wait, the rules still say that how you become a CPP, you either are board certified or you completed a residency, but if you've not completed a residency, You have to be a BS pharmacist with so many years of experience or a PharmD with so many years of experience. And then you have to have certificates in the area of practice where you're going to be conducting your collaborative practice agreement around. Well, you're no longer uploading that information. So really what's becoming more now is on you as a responsible healthcare professional. When you enter into a collaborative practice agreement, you should enter into a collaborative practice agreement only for things that you are competent and confident in your ability to provide care around. And then because those agreements are not being uploaded, but you may be applying to be a CPP for the first time, what is that joint committee basing it on? So one, they're going to look, are you board certified? Okay, let's say that's no. All right. Did you complete an ASHP accredited residency? All right, let's say that's no also. If it's a yes, then check. Essentially, you're going to be issued your CPP at that point. If both board certification and residency is not there, then they're going to look for years of experience. So there are no BS pharmacists in practice today that haven't been in practice for more than 20 years. So really it's simplified that you have to be a licensed pharmacist in our state with at least 2 years of postgraduate experience. And if you meet the 2 years of postgraduate experience, then the joint committee, because they're no longer basing it on reviewing collaborative practice agreements, you're going to be approved so that you can move forward because you have a physician that wants to collaborate with you. So this was a great deal of discussion that we had is why are we creating barriers that get in the way of us allowing physicians and pharmacists to work together? If there's a physician that wants to work with a pharmacist to provide this care, who are we to get in the way of that? And so this is the idea of how this is going to be much more simplified to be able to get approval as a CPP moving forward. All right. So let's talk about some of those key changes now. So we talked about who can be a CPP. And CPPs are required to work under a collaborative practice agreement. So now, what are the changes? And so the first thing was this healthcare services was written into scope and defined. So previously we had drug therapy management pursuant to an agreement that is physician patient disease specific. So now what we have today is this language around drug therapy, disease, and population health. So healthcare services are medical tasks, acts, or functions authorized through a written agreement by a physician and delegated to a pharmacist for the purpose of drug therapy, disease, or population health management. That is a huge change from before. This creates a lot of flexibility around what can now be provided under a collaborative agreement. Also, population health from a regulatory standpoint. So the Board of Pharmacy has addressed the addition of population health in the law. And also there's another piece that happened in the new law was the removal of any diagnosis requirement and the newly permitted broader inclusion of providers under CPAs. In a way, what this does is it greatly improves the access to more timely care. So the North Carolina Board of Pharmacy's position is that providing population health management services may include a CPP receiving referrals from healthcare providers who are not the CPP supervising physician. So one of the things when we were in the legislative building and meeting with legislators and meeting in committee meetings and behind doors with opposition and so forth, one of the things that I kept bringing up is, all right, if someone moves into the state and they need a primary care provider, what is more likely to happen? That they get a physician, a nurse practitioner, or a PA, right? So more than likely, they're going to get a nurse practitioner or a PA. So do you have to first see that nurse practitioner or that PA supervising physician before you can see the PA or the nurse practitioner? And the answer to that is no. So then the question that I kept asking was, well, then why do we want, or why do we think it's smart to require that patients have to first see the CPP's supervising physician? A lot of healthcare systems have that embedded into, from a compliance standpoint, for that doctor-patient, because of the patient-doctor specific information in our reg and in our law, that there has to be a doctor-patient relationship with the supervising physician. So now this completely goes away, right? So CPPs can now take referrals directly from other healthcare providers if that CPP supervising physician is okay with it and is willing to put it into their agreement. Another key change was predetermined drug therapy was stricken. So previously it was written in that CPPs are authorized to implement predetermined drug therapy, which includes diagnosis and product selection by the patient's physician. All of this has now been stricken, and clinical pharmacist practitioners are authorized to provide healthcare services. And remember, healthcare services on the previous slide was defined as medical tasks and acts and functions that are delegated for the purpose of drug therapy, disease management, population health management. So those things that are delegated to the clinical pharmacist practitioner as a healthcare service, the clinical pharmacist practitioner can provide it. Another key change is that we were able to override the previous prohibition of therapeutic substitution under collaborative practice agreements. So previously it said that it prohibits the substitution of a chemically dissimilar drug product. So really only thing that was allowed was brand to generic kinds of substitution. But now a supervising physician may include a statement of authorization in the written agreement to allow the CPP to conduct drug substitutions within the same therapeutic class or for biosimilar medications. What's important is this has to be done based off of the health plan's drug formulary for a patient. In other words, this was built in as kind of an ethical piece where the pharmacist that is under a collaborative agreement couldn't just be recommending the cheapest drug, right? It has to be based off of that health plan's drug formulary. And then the CPP is making if it's allowed in the agreement, the CPP has the authority to be able to do therapeutic and biosimilar substitutions. Right. Another change was the ability to prescribe devices. So previously the word device was not present in the collaborative practice statutes. So now what we have is that CPPs, device has been added alongside drug therapy and laboratory. So now a CPP can actually, if it's delegated to them, a CPP can actually prescribe devices. And so think about how many times you as a pharmacist have seen crazy things like patients that need CGM supplies, or but you have no way to actually just provide that. Right now, you've got to go talk to the physician to be able to get it prescribed so that you can then, get your patient the supplies that they need. So this creates a pathway to where you can now build into collaborative agreements with providers that you work with on a regular basis. You can build in labs, you can build in devices, as well as the ability to prescribe drugs and adjust drugs. So another collaborative practice key change, and this moves away from scope. This is now leaning into provider, site, group, and institution information. So institutional and group practices may implement site-specific multi-provider practice agreements. The institution must develop oversight for the CPPs operating under the agreement. And each CPP must have a supervising physician. And what's important about that too is that CPPs operating under the same agreement can have different supervising physicians, or they can have the same supervising physician. It's sort of a lot of flexibility is the best way that I know to describe this now. It's also, when you think about group practices and you think about a community pharmacist and a community pharmacy, that community pharmacist can craft a collaborative practice agreement that they want to enter into collaborative care with a physician or group practice, and they can shop that to different group practices in their catchment area of where they see a lot of patients bringing prescriptions in. And you can have the same agreement with multiple group practices, and that pharmacist or pharmacists, if there's more than one, has to have a supervising physician. But you don't necessarily have to have a supervising physician with every group practice. However, what's important is you have to remember the comfort level of the physicians that are entering into a collaborative agreement with you. Even though you may already have a supervising physician from Group A, if Group B wants to sign on, the physicians in Group B may insist that somebody in their group practice be a supervising physician for you as well. So, and they may be perfectly fine allowing you to be supervised by a physician over with Group A, but it may also mean that you may have to have two supervising physicians in order to be able to expand your care out to multiple groups. So let's just say that the intent around this was to really be able to expand, right? To allow CPPs to work with multiple providers and to also help our sites, particularly our group practices and our institutions, to not have to have so many different collaborative agreements to have to manage. That they could, for a site, have a very broad collaborative practice agreement that meets their needs. And Leigh will talk about that in a little bit. Fully, partially embedded. So now we have this language in our law. The healthcare setting location for the provision of healthcare services by the CPP may be fully or partially embedded for a site-specific practice. The supervising physician will determine where the care should be provided. So why did this come about? So one of the things that we talked about was, all right, we need to expand into the community. The community pharmacists can't just be in primary care all the time. They've got to be in their community pharmacies some. And what we've seen to date is a community pharmacist going into a medical group's practice for a day or a half day, a week, to be able to provide care. Why can't they provide that care in their pharmacy? Well, setting aside payment, because we know payment's a whole nother issue, but setting aside payment, can we remove the barriers that prevents the ability for community pharmacists to provide this care in their pharmacy? So that was important for us to have those conversations with legislators and with our medical partners. And it was determined that this idea of fully or partially embedded for a site-specific practice. Now, keep in mind, what's very important about this language is that site-specific, a pharmacy can be a site of practice today, whereas before it really couldn't, but now it can. If that supervising physician wants to allow you to provide all the care under your agreement in your pharmacy, they can. If they want you to deliver some care in the medical group in the office and some care, like follow-up care, in your pharmacy, then your agreement can be written in that way too. Again, a lot more flexibility. Advanced practice providers, so our nurse practitioners, our PAs, the ability to collaborate, and then the number of CPPs that can be supervised by a supervising physician. So I'm addressing both of these. There are two different provisions in the new law. We kept hearing about barriers where a clinic only has a nurse practitioner. We really need a CPP in that clinic, but our law doesn't allow for the CPP to really collaborate with the nurse practitioner, and we have no physician in that clinic to be a supervisor for that CPP. And the way compliance was sort of like really narrowing in that down. In some cases, a lot of our health systems were finding it extraordinarily difficult to be able to meet the patient needs that they had in rural communities, because their rural clinics were, for the most part, their providers were nurse practitioners and maybe some PAs. And so now we do have this ability, a supervising physician. So let's say a health system has lots of clinics, and that health system says, all right, we want to allow our nurse practitioners and PAs to have CPPs working with them. So we're going to write our collaborative agreements where the supervising physicians are enabling the nurse practitioners and the PAs that are providing care in these clinics where we need to send CPPs out to be able to allow those advanced practice providers to work together. And so that is now possible. Also, we heard about barriers prior to our new law where care would come to a screeching halt because physicians were limited to the number of CPPs that they could supervise. And maybe one was out on medical leave, another one was took a PTO day, and now there was a relief CPP coming into the care area, but that physician that was on duty wasn't the supervising physician for that CPP. So the way that care was able to be provided when the CPPs that were supervised by that physician were on site, now that way that care was being provided had to be changed, or it couldn't be as comprehensive, or they had to pivot to do things differently. And so now what we did is we said, well, why don't we just allow the physicians to decide how many CPPs they feel or that they deem that they can manage to supervise. In some cases, maybe it's one, but in other cases, maybe they say, you know what? I could really keep care going if I had 4 CPPs working with me. I want to be able to supervise all 4 of them. Why are we preventing me from being able to work with 4 or 5 CPPs? So now that barrier is also removed. So this slide is about supervision changes, and sorry, trying to get a view of my entire screen. I've got a window open that's blocking a little bit of it. So thank you for bearing with me. So some of these are the same. They're not new, but there are some things that are new. But I think what's important is that the key things that are important about supervision are on this slide. So again, you got to have a site-specific supervising physician. CPP, again, site. How site is defined can be pretty broad. It could be Rex Hospital. It could be a community pharmacy. It could be a group of long-term care facilities under the same ownership. there's many different ways to kind of define site specific. But the CPP, every CPP that is practicing at this site has to have a supervising physician. Could be the same, could be different. Collaborative practice agreements must include a plan for monthly supervision for the first 6 months, and then at least once every 6 months thereafter. And then collaborative practice agreements have to include a predetermined plan for emergency services. That is not different. That's always been there, as the supervision is the same as it's always been. But again, you have to have these moving forward under our new way of doing collaborative practice. Supervising physician must conduct a periodic review and evaluation of healthcare services provided by the CPP. That is not different. That has actually been done under the supervising meetings that have been going on. What is new is that in those meetings, you must also talk about the therapeutic substitution practices that are going on by the CPP if the collaborative practice agreement allows for therapeutic substitution. And then collaborative practice agreements should specify for each site where the CPP will practice. And so remember, it's that collaborative practice agreement, the supervising physician, that sort of talks about the location of care, like where's that care going to be provided. So that has to be in your agreement. And then the supervising physician may supervise, more than one CPP, right? And but you got to indicate in your agreements who are your CPPs, who are your providers, and who are your supervisors, right? So those types of things have to be in your agreements. So this slide, I just want to emphasize that we see, again, in the beginning, I talked about where we were prior to getting our new law passed. Very few collaborative practice agreements outside of our health systems, most of those ambulatory care. So in the upper left-hand corner is ambulatory care. We still see the highest utilization to date for CPPs has been in this area. We still see this as having tremendous growth because of the ability to expand in practice with other advanced practice providers, to be able to take referrals directly. And then also the new addition of population health these are huge game changers for AmCare. On community side, we see huge ability in rural areas to expand all kinds of care, chronic disease, care to more specific care, like for the opioid epidemic, public health needs around HIV and chlamydia and things like that. There's huge ability to build collaborative practice agreements around, if you can dream it, you can pretty much build it now into collaborative practice, and you can do it in the community setting. We also believe that there could be some very specific agreements in the community setting of where you may only have collaborative agreements around devices, like to be able to get people the things that they need to go along with their meds, peak flow meters, CGM supplies, syringes, all kinds of things that come to a screeching halt when you don't have all the tools in your toolbox, so to speak. And those collaborative agreements could get very specific. We also believe that some people may only write collaborative agreements just around therapeutic substitution. Think about how many times you have to call a doctor's office because somebody's insurance doesn't cover drug A, but they cover drug B. It's a preferred drug, better pricing for the patient. All of those, if you know the providers in your community really well, you could just do collaborative practice agreements around therapeutic substitution. Similar for long-term care. How many times I have some long-term care background. I can't tell you how many notes I wrote around labs. patients, time for labs to be, drawn, or well outside of the window, or dose titrations, patients on initial starting doses that have not been tweaked up or titrated up, and also tapers for drugs that need to be tapered down to see if a patient could be on a lower dose of something. All of these things, you repeatedly write notes after note after note after note after to try to get drug changes. You now have the ability to enter collaborative agreements, like with the medical director within a long-term care facility, to be able to have the consultant pharmacist, or maybe even your operating pharmacist on some things like around therapeutic substitution, to be able to do some collaborative practice in long-term care facilities. And then on the acute side, for me, acute is the hardest to envision because I know we have a lot of protocol-driven things on the acute care of, side of hospitals, like, dose, pharmacy to dose. Those types of protocols have been in place for a very long time. But, maybe there are things that our acute care specialists can envision that would be great changes that collaborative practice could bring about. One of the things that we thought about was maybe when you're trying to get patients out of the hospital and you get delay after delay after delay, why don't we just allow the pharmacists on the team to be able to do discharge orders around the meds, oftentimes prior authorization, be able to get those meds, get them out the door. Maybe there's the ability to have collaborative agreements written around those types of things. And then I think my last slide really is, let me see if I had another one here. I don't think I did. Nope. So I believe this is the last one. But wanted you to be aware that NCAP is building some new resources for collaborative practice. We're currently working on a web-based toolkit that will have all kinds of information, links, how-to, sample agreements, excerpts for how to do like certain components of an agreement. And then we are also developing a concierge type service or a consultant type service of where maybe you need help actually drafting your agreements. You don't have time to draft it. You've got some physicians that might be willing to work with you. If we could just help you maybe build out your agreement and make those things available for you. So we want you to be aware that NCAP has, first, we've been working on just trying to get general information out. And we've been doing that for a while now. So now we're going to shift gears to where we're developing these resources and these services to kind of help pharmacists in the field be able to take full advantage of the new flexible collaborative practice authority. All right, and at that point, I'm going to turn it over to Leigh.
Great, thank you. It's a very exciting time as I hope as Penny has walked through the law changes and what it means, that you all are getting very excited about the new doors that have opened for pharmacy. Just a couple of things to re-emphasize that Penny shared before we move into the slides, and I'll try to go through them kind of quick so we've got some time for questions at the end. But if you have questions that are already kind of stuck in your head, go ahead and drop them in the Q&A so that we can capture them. Because if we don't have time to answer them here, we certainly will take time to answer them outside of the session. But one of the biggest things that we've seen in practice is just how fast CPPs are getting licensed. Prior to October 1st, you submitted your pharmacist for CPP approval. It had to be in by the 15th of the month to be reviewed at the end of the month to find out the next month. And sometimes you found out that it wasn't right and you had to try again. It could easily take a month and a half plus to get your CPP license number. Now, with the new process, since the Board of Pharmacy is not reviewing the collaborative practice agreements and owning that piece of it, across several different health systems and colleagues that I've talked to and our own experience at UNC Health, we're seeing those CPP license issuances happening between 3 and 10 days after application, business days after application. So it's so much faster now, which is a huge win, I think, as a leader of CPPs. Also now, because you're no longer submitting it for review by the Board of Pharmacy, it is much easier to edit it and update it. So you don't have to worry about getting all the stuff in it right the first time. You've got a chance that if a provider says, hey, let's add this, or hey, I want to add that, you can now do that in real time and write it in, and it's effective pretty quickly for yourself and your team. So I think that those are some big wins that have come forward with this change. I will caveat, I'm going to go through and kind of talk about the building your collaborative practice agreement from the standpoint of you're just starting. You don't have an agreement. You don't know exactly who your supervising physician is going to be. I'm anticipating we have some people that are on the call that are in that bucket. I know just looking over the attendee list, I know we have folks that have been CPPs for a really long time, and maybe you're thinking about, well, how do I take my existing CPP that was really bound and how do I open it wide open? And I'll share what UNC Health has done, and I can speak a little bit to what Duke has done as well, because Ben Smith, who is my counterpart at Duke, he and I did a similar presentation at convention, and we spoke to that, so I can share a little bit of that. I will say that if you're part of a system or a corporate entity, it is very prudent to pass your collaborative practice agreement through your legal and compliance team members. Now that they're not being reviewed by the Board of Pharmacy for appropriateness, the burden of compliance now lies with the physician, the CPP, and the employer, essentially. And so if you are part of a system, make sure that you're sharing that with legal and compliance and getting their approval on what you're doing. They may also have some additional pit stops before you can initiate your collaborative practice agreement fully. I know with our system, and same with Duke, we have to have it. All of our CPPs have to have a DEA number. Most of our CPPs never write a controlled substance, but that's a requirement of our entities, is that all credentialed prescribers have DEA numbers. So you might have something like that, or you may not. You may also have to go through privileging and credentialing. So just know that the collaborative practice agreement is one piece. There may be other things that you need to think about and do as well. But on the next slide, we're going to focus in on what do you need to think about as you begin your collaborative practice agreement. So I've had the opportunity to jump into a site that was already developed. I've had the opportunity to build a site from scratch with providers that had no idea what to do with a pharmacist. And I've had the opportunity to build and scale at a system level. So I've seen a lot of different flavors of this. And so I just want to share some of the things that I've learned along the way and things that I've heard and learned from other colleagues as they've done it. The first most important thing is to build and grow your relationships. So the best way to have conversations with providers that you're thinking about might be a good partner for you is to ask and get yourself invited to attend a provider meeting, a practice meeting, where you can sit down and talk to them. You may want to invite the medical director at that practice into your pharmacy to talk to them and let them see your setup, to understand, if you're in a community space, what your counseling room looks like, what your services look like, so that when they're thinking about you and your pharmacy, they can think about it through a corrected lens, so to speak. I will tell you, you'll hear mixed things when you go and talk to providers, and it's happened every time I've gone and talked to a group of providers about adding CPP services. There may be one or two, if you're lucky, that have worked with a CPP before, either in their training or in another practice. But more often than not, you're probably going to have providers that have no idea what a CPP is or how you can help them. And you may have some that will sit there and tell you straight, I don't think I need you, and I'm probably not going to use you. And that's okay, because in a multi-provider practice, you really only need one or two providers to be a referral source for you and to be your cheerleader. The others will come along. They will see how their colleagues' patients are improving, how their work balance is improving, and they will trickle in, but they'll be more on that late adopter scale. But really nurture and grow those relationships. As you're getting into your trial, as you're getting into like figuring out what you're going to do and launching your service and measuring and iterating and delivering and expanding, I would encourage you to put it on a trial period. You decide what that is. I've historically used somewhere 6 to 12 months. That really gives protection for you that if it's not working out, you've got an easy out. It also gives an opportunity for the practice or your supervising physician that if it's not working out for them, they've got an easy out as well. So I think that makes it a little safer of a risk sometimes for the practices that you may be engaging. I would encourage you to start with a small problem that they have. Ask them when you're talking to them, what are your challenges? Prioritize that list with them, and then pick one or two that you feel that you can really knock out of the park. And then tell them how you can help, because they may not be able to envision all the things that you can do, but they can certainly tell you what their challenges are. Expect to iterate. You're going to have a lot of learning opportunities. They're not failures, they're learning opportunities. It's important to rethink. It's super necessary to do that and just continue to iterate and grow alongside of your practice. It can be easy to get frustrated. Try not to. Just look at it as, how can we improve this? What can we learn? How can we make it better? I will say delivering results is one of the more important things that you need to think about on the front end. And a lot of times that gets left to the back end, and then it's really hard. So the more you can talk about what are the deliverables, what does that provider want to see, that practice want to see, pick those measures that are going to matter to them. And remember, you can measure a lot of things, but you do not need to measure all the things. And then also for things that are hard to measure in numbers, patient stories go a really long way. So encourage your patients to tell their story. Encourage your patients to let you have them tell their story in a way that you can then use it as testimonials as you're marketing your services, and then be ready to expand because they will ask you to expand. Next slide. So as you're thinking about the partners in your neighborhood, they're everywhere. Primary care is an easy place because there's a lot that CPPs in community settings and in ambulatory care spaces can do for primary care providers to help. Specialists are also great opportunities as well. Our team has had a lot of success partnering with our weight management physicians and our endocrinologists across our system to largely serve as med titration resources for their teams and their practices. If your idea is something more that's like a public health idea, engage your public health department medical director. They tend to be very open to that more global view of how you can approach and support care. Urgent cares are another great place to think about partnering. They get slammed. And there's a lot of things that we can do now that would help offload some of that urgent care burden, and also serve as a place for urgent care to say, when they get flooded, to say, it's going to be a 4-hour wait here for us to do XYZ, but the pharmacy down the street or our CPP can do this for you, and you don't have as much of a wait. Local hospitals are a great resource also, because they are always looking for ways to decrease admissions and readmissions and length of stays. There's a lot of burden around med rec and transitions of care, so there's also great resources within your local hospitals as far as finding partners. When you're engaging with these partners and you're having these conversations, it's very important that you're crafting the message well. The way that we have found has been very successful is crafting it around improving access to care for the patient. So our health system has a measure of how long it takes to get into a visit for a new patient, how long it takes to get in for a visit for a returning patient. Most health systems and ambulatory care spaces have similar measures, and we're right in there with everybody else. It's 3 months plus, depending on what you're trying to get in to be seen for, to be able to get a visit. A lot can happen to a patient and go really wrong in the course of that 3 months while they're waiting to get back in or to get in the first time. So if you can craft your message around how you can improve care access, that's going to be a huge win for them. How you're creating capacity in those physicians and APP, advanced practice providers day, is also going to be really helpful to them. they can't titrate all those patients' medicines for blood pressure and GLP-1s and insulins and all the other things that need to be titrated or de-escalated. They don't have time to do that. They can't get the patients in. And if you can present to them that you can take ownership of that process for that patient, that's a huge thing that they are generally more than willing to hand right over. And that's a great place for CPPs to be involved with. Emphasizing that you're providing convenient care, particularly in our community pharmacies where you're closer a lot of times in our rural areas to where the patient lives. You also likely have better hours and potentially some weekend hours for patients that their primary care or their other points of care are not going to be able to deliver on. So being able to say, if something comes up for your patient and it's after hours, I can work with them. I can help them so they're not having to take off work or they're not having childcare issues or transportation issues. I can help them in times that are more convenient for them. That speaks loudly to your provider population. The last thing that has been growing over the past couple of decades is supporting value care and quality measure work. Most practices now have quality care and value care arrangements where they are incentivized for getting their patients with diabetes to their A1C goal, getting their patients with hypertension to their blood pressure goal, helping to get patients on statins and appropriate intensity of statins, helping patients get certain tests done in a timely manner. All those things are great places for you and your collaborative practice agreement. The next slide, I won't go into a lot of detail. Penny already mentioned a few of these, but these are just some right off the top of my head problems that they have in primary and specialty care and ways a pharmacist can solve it. Weight management titration. Unless you've been living under a rock, you know that there is a new benefit coming to our Medicare beneficiaries in a few days. Patients are going to have new access to GLP-1s for weight management within our Medicare population. Somebody's going to need to titrate all of those GLP-1s for those patients. Who better than a CPP to do that and to be able to take that work on? We are finding more and more that our physicians are wanting to give us what's left of their warfarin, their patients that are on warfarin, because there's not many anymore, but there still are quite a few, and there's good reasons why those patients are on warfarin. Because it's not as mainstream in practice, the physicians and APPs are a little rustier than they used to be. And we've known for a long time pharmacists do that exceptionally well, adjusting warfarin. But now there's even greater opportunity to do that within your communities because that's kind of rusty information to your provider populations. Test and treat beyond influenza would also be a possibility within a collaborative practice agreement. So that you can provide more complete testing and assessment of those patients with respiratory illnesses. Oh, we are running all out of time. Choosing your words for your CPP or your CPA. Penny on key change 8 on slide 20 gave you the things that are non-negotiable, so the things that have to be in your collaborative practice agreement. There are opportunities in there for you to negotiate with your provider what you want in there and how that's going to look. 2 different approaches that I've seen, specific and targeted, which is, you take a problem and a solution that was on the slide prior, and you build that very clearly. It's very succinct into your collaborative practice agreement. You may want check boxes or lists broad, like these disease states, these therapeutic categories of medications, like medications indicated for diabetes, versus before it had to be much more specific than that. Broad laboratories and tests. So you can have it worded like that, or you can take more of a broad, vague approach that is more defined by the function and the service. And that's the approach that UNC is actually taking with our system-wide uniform collaborative practice agreement. How many backup physicians you have, that's again negotiable. I would definitely recommend at least one, just so that you don't end up high and dry if your primary physician leaves the practice or is out for an extended period. So, just things to think about there. And then which patients? Are you limiting it to patients specific to that practice? Are you going to be open to referrals? Are you going to take more of a community public health approach? The next slide, I'm not going to read it because it's a lot, but it's more here just for you to see what it would look like if you do broad wording. that is more defined on a functional and service-based delegation versus spelling out any specific diseases or med classes or labs or anything like that. So this is actually what is in our new CPA that is working its way through physician groups and then legal and compliance. But it has come all the way through all the different chains of pharmacy within our health system that basically just allows the pharmacist to do what they are credentialed and privileged to do, that is within the scope of what they've been trained to do. And just making an acknowledgement that we know the boundaries of our competence, and when we hit that boundary, we're going to tag in and phone a friend. But if your health system is looking, or if you're thinking about how do I make my CPA broader, this is one way that you can think about doing that. Next slide. Real quick, just as far as thinking about measures and what are you going to measure? You can measure a lot of things, but not everything needs to be measured. And the more things that you say you're going to measure, the more work you're putting on yourself, and the less time you're going to have to spend doing things, because you're going to have to spend so much time measuring the things that you're doing. So I would say it's important to get your key stakeholders to the table early, decide what is important to them as far as what they need, what data they need to make decisions to continue the relationship or expand the relationship, what you need for those things, and then have a mix of counting things, which is the quantitative data, and describing things, which is the qualitative data. And again, to my earlier comment, the patient stories speak so much louder than numbers. So every opportunity you have to have a patient give a testimonial, either written or video, will serve you well. I think I saw a question about billing. Billing is a whole nother can of worms that we would need a whole nother session to talk about. But here are a few ways that you can bill for your services in ways that can sustain the CPP's salary and the ability to provide the services. And my last slide, I think, is just grow as you go. There's a lot of different ways to grow. Integrating your services within the electronic medical record, having your providers give you access into their EMRs so that you can put your notes there and you can see the patient's records in there will be hugely helpful as you're providing your services. Adding new partners, so finding additional practices in your community that you can pull in under your agreements, adding new services, marketing, being creative, looking for new business models, and then sharing your expertise. The NCAP huddles are a great resource for sharing and learning together. Publishing and putting posters at NCAP convention and through different platforms is also another way to share and learn. And then precepting students is a great value add because they see a lot of things, so they can help bring back information to you in your site and help you refine and adapt. That was really fast. I'm sorry. We blew through that super fast.
No, that was great information.